All right, I think we're going to get started here. Welcome everyone to our webinar, Breathing Easy Through 2024, Preventing and Managing Respiratory Illnesses. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota. We are a nonprofit organization established in 2022 with the mission to promote health and wellness across North Dakota at the community level. We are expanding our statewide coalition to foster, excuse me, speaking of respiratory illnesses, I am suffering of a little bit of a cough, collaboration among local communities on common initiatives. And by becoming a member of the coalition, you will be the first to receive information about educational opportunities like this one, updates on relevant public health information, legislative news, as well as access to digital advocacy resources and toolkits. Just some housekeeping items to talk about is webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the chat box. We are recording the presentation and we'll leave time in the end to answer any questions. After the presentation, a link to the recording will be sent out along with an evaluation survey. It's my pleasure to introduce our presenter today. Dr. Hanson is originally from Mayville, North Dakota. She attended Creighton University for medical school and her pediatrics residency at the University of Wisconsin. She has been with Sanford for 16 years and is a general pediatrician, providing primary and acute care for children from birth through 18 years. She treats a variety of childhood illnesses and chronic health conditions and behavioral health concerns and provides health education and wellness counseling. She is the Chief of Service of Sanford Children's in the Fargo region and also serves as the Department Chair for the Pediatric Urgent Care and the Child Maltreatment Program. She actively participates in governance through roles on the Credentialing Committee, PEC, Board of Directors, and the Council of Governors in and is a clinical faculty member for the University of North Dakota Medical School. We are so excited to have you here again, and I will turn it over to you now.
Thank you so much for having me back. I'm just going to share my screen here and get my slides going. Make sure that works out. Whoops, wrong one. Go back. There we go. Can you see the slides okay, Mary?
I sure can.
All right, great. Well, some of you might remember I was with this group last year to talk about respiratory illness, but specifically focused on RSV. And Mary and I were talking a little bit about, what would I want to bring to the group this time? And she said, well, we're heading into cold and flu season. Maybe we could just do a more general update about respiratory illness. And I'll tell you, here in Fargo, from the minute school started, which was over a month ago now, we've just seen kind of that typical fall explosion of coughs and colds. And many of us as providers are gearing up and getting ready for the winter ahead and maybe feeling a little bit nervous about that. So we'll talk a little bit about just, kind of respiratory season in general, some of the facts we know about that. I'll talk about some specific illnesses, and then we'll dive into prevention, home treatment, when to seek medical care, and I'll also share a case study of a patient that I cared for with a respiratory illness. So we'll kind of walk through here. I don't have any disclosures to report. Like Mary said, I'm a practicing pediatrician. I've been with Sanford for 16 years, and I've cared for probably thousands of children with respiratory illnesses over that time. It is the bread and butter work of any primary care provider, but particularly pediatricians. And we do a lot of counseling and education related to that. My only sick days off during my 3-year residency was when I had RSV. I was rotating through the NICU at that time, and they definitely did not want me there. So that was just something that was kind of a bump in the road for me, for sure. So why this focus on respiratory health? We know that kids are especially vulnerable to infectious illness, but especially kids under the age of 5 years. They just don't have that memory immunity present yet. They're just not at a point where they've been exposed to the wide variety of viral pathogens. So we know that those kids are more likely to be sick. There is some changing epidemiology and some new viral strains. So those are maybe some new or recurrent risks. Infection rates of illnesses are returning or exceeding pre-pandemic levels. So you might remember during COVID, when we all retreated inside and we were masking and social distancing, we really saw rates of influenza, RSV, pertussis, everything just plummeted during that time. And we're now at a point where, sort of our everyday lives have returned back to typical patterns. And so we're seeing those infection rates come back to what we saw before the pandemic. Most kids recover quickly from respiratory illness, but it can be serious. It can lead to medical care, hospitalization, sometimes even death. And so I think it's important for us to recognize that we have vulnerable populations and that kids can be susceptible to some of those more serious illnesses related to typical viral pathogens. And our childcare settings and our schools play a role in spreading infections to our communities. Those kids gather in close quarters, they share their germs with each other, but then they bring it home. They bring it home to their siblings, they bring it home to their parents, their grandparents, and that really does incite some community spread. So lots of factors for us to consider here as we're talking about respiratory health. I thought this was hilarious, the types of sick kid noses. I don't know how grossed out you all are by snot. I'm fairly grossed out by snot myself, but I'm pretty sure my kid has experienced each one of these within the same respiratory season. So just a little humor in there. Some of the more common pediatric respiratory illnesses we deal with, of course, numerous viral infections. So you're probably all familiar with these: RSV, influenza, COVID-19 are some of the big players. Para-influenza is the virus that's responsible for croup. And then the common cold viruses, of which there are more than 200 strains. And those are what predominate kind of our fall and winter months. But we can also see bacterial infections during that time. Our community-acquired pneumonias, which are largely viral, but can also be bacterial, and pertussis. A lot of you might have seen that pertussis is making a comeback, and we're seeing increased numbers all over the country, including in North Dakota. We're seeing increased cases, mainly concentrated in Cass County in the Fargo-Moorhead area, and are closely watching that. Transmission and spread, we typically talk about either droplet or contact spread. Those droplet spread, those are those infectious particles that are passed through our airway and contained in spit. So you can spread those through talking, singing, laughing, of course, coughing and sneezing. Those are droplets that are transmissible through the air to another person, but over a relatively short distance, maybe in the neighborhood of 3 to 6 feet. So that is, people that you are sitting closely to, spending extended periods of time with, maybe people that share your home with you. That droplet spread comes into play. That's different than viruses that spread that are aerosolized. So aerosolized viruses are things like measles, where those particles are much, much smaller. They can really get into a much wider area of spread. So droplet spread is one of the main methods for respiratory viruses to transmit. And then there's contact spread, which is basically those respiratory droplets landing on a surface that you then come into contact to. So those are things like doorknobs and table surfaces, glassware or eating utensils, handshakes. So it's that direct contact, person-to-person spread, where you touch the object and then touch your own face or nose, and the virus is able to transmit that way. Those viruses can live on surfaces for a certain period of time. It really depends on the virus and how durable they are, but that is a known method of spread as well. The seasonality of respiratory illness, this is something that has been observed in human populations for thousands and thousands of years. And even Hippocrates in 400 BC wrote about this sort of winter season outbreak of respiratory illness in the area that he was living. So this is something that's been observed, and of course through history and our understanding of germ theory, many different reasons have been suggested for why this happens. You know, back in Hippocrates' time, they didn't know that germs existed, that infections could be spread from person to person. So I'm sure they had some pretty wacky ideas about how that was happening, but nonetheless, they did recognize that there was a pattern of seasonality to it. And those mechanisms are actually still somewhat under debate. The two main reasons, though, that we think about it are changes in our environment, both the outdoor environment and our environment in our dwellings that happens from season to season, and also changes in human behavior from season to season. When the air gets cold outside, the humidity naturally drops, so we have drier air. When we turn the heat on inside, that dries out our air as well. So we see that change in environment, both in temperature and humidity, which has an effect on the human body and our defense mechanisms. That air will dry out our mucosa. It can impair the action of the cilia that help to move mucus effectively through our airway, and it increases our mucin production. So that dry air actually can impact your physical barrier against infection. There's also theorized that a shorter daylight period leads to a relative vitamin D deficiency, and that can impair your immune function in clearing pathogens. So, you know, maybe grandma was right. Maybe spending time in the cold does lead to you getting sick. Maybe not in the way that she was thinking, but there is possibly some truth to that idea that our environment can impact our defense mechanisms. There's been some really interesting research too that looks at the relative humidity levels and viral survival in those environments. And it turns out that those droplets that we talked about can spread through the air more easily in a dry environment. When the air is more humid, they can't hang out in the air as long, and that may actually play a role in preventing spread as well. So we'll talk here quick about RSV. We touched on this at my last talk, but RSV is still, for most people, adults, children, infants, it is still usually an upper respiratory infection. So a cold. You might not know that you have RSV, but you know, because it's the typical cough, runny nose, maybe a little bit of fever. But where we worry about this, of course, is in infants, especially younger infants and the elderly. So 20 to 30% of infants will develop a lower respiratory infection. So rather than being confined to the nose, the throat, it's actually down into the lungs where they can develop either a viral pneumonia or what we call bronchiolitis, which is that sort of mucousy wheezing condition that a lot of infants get in the winter. It's especially risky in the first few weeks of life. They may have actually more vague symptoms with lethargy, irritability, poor feeding, and the most risky part, apnea, where they actually stop breathing. It's the leading cause of infant hospitalization in the US, and typically about 60 to 80,000 cases per year. Little tough to track the numbers, but on average, we see somewhere anywhere from 100 to 500 deaths of children under the age of 5 each year in the US due to RSV. So while it is typically mild, it can be more serious. And we take care of children in our hospital here in Fargo every year that have RSV. That kind of predominates our winter season. So here's a little baby that's in the hospital with RSV, and you can see the main treatment they're getting here is supplemental oxygen being delivered through a nasal cannula, IV fluids being given through a scalp IV, and then that baby also has a feeding tube because due to their nasal congestion and their work of breathing, they're not able to eat orally. So important to maintain hydration, important to maintain oxygenation. And this is just an example of a chest x-ray with an infant with RSV. And you can see there's, you know, it's just got that kind of hazy kind of, you know, you can just see that throughout the lungs are affected there, but there's no definite pneumonia or specific area of concern. And what happens in RSV is the airways down in the lungs tend to have increased mucus production. So it's a obstructive process where it's difficult for air to reach all the areas that it needs to. Our friend influenza. So you know, we expect this every season. This is something, again, that's been present for thousands of years. Typically, influenza is a very abrupt onset. Patients will often describe it. I was fine 1 minute, and then the next I was flat on my back. I felt like I got hit by a train. And typically they have, fever, malaise, myalgia, those body aches, but it'll also have cough, sore throat, rhinitis, and you can have a huge variety of complications related to influenza. Otitis media, croup, you can develop either a viral pneumonia or secondary bacterial pneumonia. There can be some cardiac effects from influenza virus, including inflammation of the heart itself, the heart muscle itself, or the lining around the heart. But you can also develop central nervous system related effects. So an encephalopathy, encephalitis, transverse myelitis, which affects the spinal cord, and acute disseminated encephalomyelitis, which is as bad as it sounds. In the 2023-2024 season, there was a kind of a landmark. We had 200 pediatric deaths in the US due to influenza and around 20,000 hospitalizations. That was a somewhat higher number than we've been seeing in past years, and we're noting that is looking to be a little bit on the rise again. So yeah, bad gift at Christmas time, fruitcake. Worst gift, influenza. And I think we've all experienced that. You go to the family gathering and you came home with more than you bargained for, whether that's a gastroenteritis or a respiratory infection. I'd take the fruitcake any day, personally. COVID-19, the hot topic everybody still has questions about, even, almost 5 years later. COVID-19 still continues to have a wide range of symptoms. It is definitely still present in our communities. It is no longer in pandemic state. Pandemic is done, and it's really turned to more of an endemic illness with seasonal fluctuations, similar to influenza. It's got a super wide range of symptoms, no matter what your age is. You can have zero symptoms. You can be infected with COVID and be completely asymptomatic, or you can have extremely severe symptoms. But I would say the typical course is anywhere from mild to moderate with a fever, cough, runny nose. Kids in particular may have GI symptoms along with it, with nausea, vomiting, or diarrhea. There is a condition called MIS-C, or multisystem inflammatory syndrome, in children. This is a systemic condition that happens usually within 2 months of a COVID-19 infection and can be very severe. It affects the inflammation of the blood vessels, the eyes, the internal organs, and kids with this typically require ICU care and very specialized treatment, and it can be a life-threatening condition. But there's also long COVID or other post-viral syndromes, and we can see these in youth as well as in adults. So, pretty wide gamut there of what COVID-19 can do to the body, and honestly not dissimilar to some of our other viruses. Influenza can be, a very mild nothing burger, or it can be life-threatening or even deadly. So we see a wide range of responses to that. In COVID, it was a little hard for me to find exact numbers for just the past year, but we think there were probably around 17,000 hospitalizations since the fall of 2023 in kids in that 0 to 4 years age range. Now I want you to look back at influenza, around 20,000 hospitalizations. So I think many people have this idea that COVID is less severe in kids, but it is still actually a big cause of hospitalizations. And of note, half of those patients hospitalized had no underlying chronic conditions. So again, I think we thought for quite a while that, well, kids with asthma or kids with, chronic developmental disorders or cerebral palsy were maybe more prone to severe COVID. That might not actually be true, though those patients are actually at risk. And best I could find in terms of death statistics, it sounds like there were roughly 1,500 deaths in persons less than 18 years of age since the pandemic began. So, 4+ years for that time frame. But if you divide it out over 4 years, not that death rate has been happening equally over those years, you start to see this numbers emerge that it might not be actually that dissimilar from influenza in terms of effect on patients. I like this graphic. There's been a lot of lingo thrown around that refers to that seasonal spike in COVID, RSV, and flu, whether that's flu-rona or, however you like to spell it. There's a lot of overlap in symptomatology between those viruses. and all of them can present in kids over the winter months. Going to shift gears a little bit and talk about pertussis. As I mentioned, cases of pertussis tend to be on the rise over the past couple of years. It's really difficult to diagnose pertussis, as it turns out, because it has a lot of overlap with mild common cold symptoms in the early stages. And coincidentally, that's the stage of pertussis that's actually the most infectious to others. So, low-grade fever, runny nose, and an occasional cough for about a week. Who would get excited about that? Certainly not me. Certainly if my kid had, low-grade fever and a little bit of runny nose, pertussis would not be, in the top 10 things in my mind that would be going on with her. Where it gets trickier is as you progress through the stages of this illness. So stage 2 is you develop this very intense cough that rightly can be described as violent. And it's just these paroxysms of cough, or cough, 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 very hard to catch your breath, very uncomfortable. It's just exhausting for patients that go through that. And often you cough so hard that you gag and vomit after coughing. That stage can last such a long time. We're talking anywhere from about 2 to 8 weeks where that part is happening. And then that's followed by a recovery period where your cough slowly starts to abate, but you're still highly susceptible to other infections because you've had this level of inflammation in your lungs. Their defense mechanisms are down. And so anytime you get sick again after that, you just are developing this kind of exaggerated response to those illnesses. So really can be quite a doozy, and it would not be unusual for someone with pertussis to have, from start to finish illness that's lasting at least 3 to 4 months. Infants, however, may have a different set of symptoms and be affected in more of a severe way. And so apnea is the biggest issue there, where they're actually stopping breathing, but also developing pneumonia, encephalitis, seizures. So a pretty severe set of symptoms and higher risk of death from that. We're looking at probably somewhere around 10,000 cases per year, with estimated 15 deaths in the US from January 23 to May 24. I think in August, we had a bulletin from the North Dakota Department of Public Health that said we had 13 cases, had counted up to 13 cases of pertussis in Cass County, with 1 hospitalization and no deaths associated with that. You look at those numbers and you say, well, gosh, if this is so infectious and so problematic, why are we not seeing the same numbers that we would see with influenza or some of those other viral illnesses? And I think you got to keep in mind that our rates of vaccination for pertussis are actually really high. As part of the infant immunization series with booster doses later on, we probably about 95% of patients are covered by Tdap vaccine. And that really does do a fairly good job of helping to keep these cases suppressed, which is great news because of its infectious nature and its severe effect on infants. I'm going to try to get this video to play, but if you've never heard what pertussis sounds like, or whooping cough, here's an example of it. We'll see if you can hear it. I'm not really sure if you guys could hear that or not. It's tough to tell on my end.
Yeah, it was a little bit, but it was a little tough to hear.
Yeah, basically it's that paroxysm of cough. Kind of like when you're choking on something and you're just coughing so hard that you can't even get in a deep breath. And then when the kid in the recording breathes, it's that characteristic whoop sound where you're doing that really forced inspiration, trying to fill your lungs out because you've just emptied them out with forced exhalation with coughing. So just very intense. And if you've ever had a coughing fit and you know what that felt like, now picture doing that for like 6 weeks straight. You're not going to sleep well. You're not going to perform well. It's going to be tough on you. So pertussis is a tricky one. Parainfluenza, this is the germ that causes croup. So this is a viral illness again. A lot of us as parents have experienced croup in our kids, but just a refresher, it tends to affect the upper airway a little bit more frequently. So again, it's those common symptoms of fever, runny nose, cough, very similar to a common cold. In younger kids, can be more severe, and you get that really barking cough. It sounds like a seal barking, where it's hoarse, just that or kind of sound. And then those kids often have stridor, which is an inspiratory noise due to inflammation in the airway. So just sitting and hanging out, they'll often have a when they're breathing. Parainfluenza can affect the lower airway as well. So in that case, they may have more of a wheezing situation with bronchitis, bronchiolitis, pneumonia. I'm going to try to do this video too. I'll turn the volume up a little bit. This one actually has a video component too, where you can see that this kid is also having respiratory distress that's visible. So she's retracting when she tries to breathe in. She's in the emergency room. So you can sort of hear that it's different than the cough that goes along with whooping cough. I mean, that's just a very intense, like, like I said, like a coughing fit. When you hear croup, the noise almost doesn't sound human. It sounds like it's coming from an animal, like I said, like a seal, or some people compare it to a fox yipping or crying. It's a very hoarse, very unnatural sound. And you could see in the video that kid, she appeared anxious. She was reaching for her caregiver. She had some tugging at the base of her throat, where she was really using some of those accessory muscles to breathe, as well as her belly. So she had both that barky cough and then also had inspiratory stridor present. So parainfluenza, like if you've experienced it, it's scary. When you hear your kid breathing like that, they appear scared. They're having trouble getting air in. And that definitely can put them in some dire straits too. Go back to that too. There are kids who require hospitalization from croup, but I would say the main place that we see these kids is in the emergency room or in the pediatric urgent care, where the kid wakes up in the middle of the night, they have this rough breathing, they're brought in by parents or by ambulance and able to be effectively treated and released back home again. But definitely a cause of illness in our winter months. Community acquired pneumonia. So this is kind of a bucket term that refers to any type of pneumonia that you acquire in a community setting. So this is different than a hospital acquired pneumonia or a ventilator associated pneumonia. So those are sort of the three main categories. Community acquired pneumonia, common cause of illness in the winter months. And it's actually the leading cause of death for children less than 5 years of age globally. We have 100,000 hospitalizations in the US annually for community-acquired pneumonia. And again, that number is high because it encompasses a variety of different pathogens within that envelope. You can have viral causes, bacterial causes, fungal causes. It is also can be challenging to diagnose and treat because you don't always know what the causative organism is. Trying to differentiate between bacterial and viral causes is not always easy to do. Pictures down in the corner are two of the common bacterial causes of pneumonia. The one on the left is mycoplasma, more referred to as atypical pneumonia or walking pneumonia, if you've ever heard that term. And then the one on the right is the kind of well-known pneumococcal pneumonia. So that's the one that tends to impact younger kids or is that kind of more classic bacterial pneumonia. These kids may present, again, similar to some of the other illnesses we talked about: fever, cough, labored breathing, chest pain. I would say in my experience, these kids tend to look a little bit sicker. They tend to be a little bit more uncomfortable. and may have more difficulty breathing or lower oxygen levels than some of the other illnesses. Community-acquired pneumonia also can be a complication of some of the viral illnesses we talked about. So you can have influenza and then develop a community-acquired bacterial pneumonia on top of that. And we'll call that sometimes a secondary bacterial pneumonia. We take care of kids in the hospital all year round with pneumonia, but it is higher prevalence in our winter months. Some of these bacterial pneumonias are vaccine preventable and some of them are not. So it really depends on what germ you're dealing with. This is an example of an x-ray of a kid with a bacterial pneumonia. So you can see over here on the right, there's this kind of more hazy area showing up on the x-ray, and that's evidence of an infiltrate or a collection of inflammation, bacteria, pus, mucus, kind of all consolidated in that area. So that's consistent with a bacterial pneumonia. This is just for entertainment purposes, but this is a contraption called the pigastat, and this is a restraint device that's used for x-raying young children. You can see that baby's is pictured with her arms up in the air to give good exposure of the lung fields. This was designed to actually reduce radiation exposure to infants and young children because it avoids the need to have to reshoot images or redo x-rays. It also avoids the need to expose a second person to radiation, restraining the child. So looks like a torture chamber. I've heard it referred to as a baby trap or a baby blender, but these are in use in a lot of organizations. And that's why oftentimes when you see a infant x-ray, you see them with their arms up in the air like that. I've learned to warn people about this if I'm having their child get an x-ray, just so they're not caught off guard when they get there. And even though it looks horrible, generally babies tolerate it pretty well, or they're in a situation where they're not feeling good and they're going to be upset no matter who or what is restraining them. So allows us to get high quality pictures and improve our diagnostic accuracy. It's named pigastat came from its inventor. So stat refers to stationary or being still, but pig is actually the name of the inventor, Jimmy Pig. So it's named after him. I'm going to talk, kind of divert here and talk about a case study. This is a patient that I took care of very early on in my career here at Sanford. And at that time, I was working part-time as a hospitalist. So I was taking care of pediatric patients in the hospital and also working in the primary care clinic. So I was kind of rotating back and forth. And I first met this child in our children's hospital in Fargo during her illness. But just to set the stage for you, she is an 11-year-old, very healthy young girl, really has not had any illnesses at all. She's not, never had any stays in the hospital. She lives on a farm in Western Minnesota, and she's in 6th grade. She loves animals. She's a straight A student. She just started in band, and she does martial arts. And she lives with her family on this farm, and life is good. Like I said, she got no prior health conditions, no asthma, no diabetes, no issues with her health over her life. One of the reasons I picked this case was because of the date. So this is October 12th, 2009. So very close in time of year that we're at right now. And thinking back, turn back the clock to 2009. Some of you probably remember that was the year of H1N1 influenza. This was or swine flu as it was colloquially called. So this was a super virulent strain of flu that was circulating, and we had a lot of attention to that. It was also the year, though, in Fargo. This was about 6 months after the historic Fargo flood. So our community and our region had just been ransacked by this flood. We were still in the recovery phase. And then we get into fall and winter months, and we're like, oh, great, now we have to deal with swine flu. So my memories of that year are all rooted in terribleness, all the terrible things that happened. So October 12th, 2009, this young lady developed a sore throat and a runny nose, just like probably 2/3 of our community has right now, just some very basic upper respiratory symptoms. Over the next 5 days, her symptoms progressed. So she's at home. She's actually still going to school. until things started to take kind of a turn for the worse. And she developed a fever up in the 103, 104 range. She had a headache, now had a productive cough where she's coughing up mucus, but had some back pain and a rash along with that. So that was a little bit unusual. It's kind of a little gives you the sense her symptoms were starting to get a little bit more severe and a little bit more problematic for her. And again, she's 5 days into her illness at this point. She was seen in her local ER on day 5, and they took a look at her. Looking at the rash and noting that she had a sore throat, they did a strep test, which was negative. And they said, well, you look okay. You're not dehydrated. Yes, you're uncomfortable, but this is probably a viral illness, and we're going to have you go home and just kind of, take some ibuprofen, drink fluids, rest, and you'll probably get over that. That is not unusual advice that we would give early in a respiratory illness. We really pay attention to how does the patient look? Are they dehydrated? Are they in distress? And none of those situations applied to her. So she was safe to go home and continue doing what she was doing. Over the next 3 days, she had significant worsening of her symptoms. So started to have now more difficulty with her breathing, had worsening of her back pain. This would not be characteristic of the illnesses that we walked through, where your fever is getting worse, your pain is getting worse, your breathing is getting worse as your illness progresses. Typically when you have a respiratory illness, especially common cold or a more milder influenza or RSV, you kind of have this initial burst of symptoms and it maybe hits its peak after a few days, and then you should have gradual improvement. That's not her story. Clinically, we should be concerned at this point because she's on day 8 of her illness and she's getting worse instead of better. So she ended up getting admitted to the hospital in Detroit Lakes, and they found that she was positive for influenza A, but also had a secondary bacterial pneumonia. So she was put on oxygen and transferred by ambulance to Fargo because she needed a higher level of care. She needed the Children's Hospital. This is not her x-ray, but this is very much what her x-ray looked like, except the reverse. Her pneumonia was on the right side. So you can see she has this huge whited out area of the lung. That's probably 2/3 of her right lung. And that's something called a pleural effusion, and also had evidence of an empyema. So there was a collection of fluid surrounding the lung, but also that had developed pockets of pus, and inside of that, in the lung, pneumonia. She also had evidence of pneumonia in the left lung as well. So she was in a bad way. That's a very icky looking x-ray. Coupled with that, she was having very significant symptoms too. So like I said, she had 2/3 of her lung whited out with a large pneumonia and an empyema with an effusion. She had this pneumonia in the left lung as well. She actually required ICU care for this. She needed a central line to help deliver fluids and antibiotics and help to support her if she became sicker. This is a high risk for sepsis. But she also needed a chest tube placed, so a tube that went through her chest wall to help drain that fluid that was surrounding the lung, and that would allow the lung to expand. Unfortunately, within 2 days of her admission, she actually developed acute renal failure and anemia. So she's continuing to get sicker. Some of that was a consequence of the medications that were being used to treat the pneumonia. So she had complications related to that, and ended up having bronchoscopy and just was very, very sick. She needed IV nutrition and was not able to eat or drink anything, and really was on oxygen and a lot of support. So she had a total of a 14-day hospital stay. That's almost unheard of for a pediatric patient. Usually those kids come in with pneumonia or respiratory illness, they stay for a few days, we tune them up and they go back home. But a 14-day hospital stay for this otherwise very healthy 11-year-old. And she very luckily had a full recovery. She had resumption of her renal function and had no lasting effects from that. Her pneumonia, her empyema all cleared. But holy cats, this kid missed a total of 6 weeks of school. And if you have kids in school, you know what a burden it is for them to miss even a few days due to illness, but 6 weeks of school is brutal. That's a significant impact on her education, but also a significant impact on her family, because that affected their ability to work and earn income for their family. And the trauma that this had on them and on this girl was pretty significant too. There was a point during her hospitalization where they didn't know what was going to happen. They didn't know if she was going to need dialysis. They didn't know if she was going to be permanently affected by this infection. They didn't know if she was going to die. So their previously healthy kid got super, super sick in just a matter of days because of influenza. And that I bring this case not to be scary about it or anything like that, but to just say there are kids in our own community who have had, devastating impact of some of these viral infections that we see every single year. And we got to be on our game. We got to make sure that we're doing our best work for our families, for our patients, for our communities to help prevent these illnesses as much as possible. And like I said, thankfully, this young lady made a full recovery. Some kids are not that lucky. Some kids do have permanent disability from these infections or even death. After she discharged from the hospital, I ended up becoming her primary care doctor. So I got to take care of her throughout her teenage years and into her young adulthood. And now I'm actually the doctor of her 3 children. So that's been a really fun thing to watch her grow and have her own family over time. And you better believe after she recovered from this illness, her entire family was first in line for influenza vaccine every single year after that. And her children are all vaccinated for influenza, COVID, now RSV, that has gotten, really has seen what these illnesses can do to an otherwise healthy person and want to do their best to help prevent that. So we'll talk prevention. This is something that's relevant for all of us. We all get sick in the winter. We all are seeing this in our communities. Just like I said, vaccination is one of our strongest tactics that we have to not only try to prevent these infections from happening, but also reducing their severity. And I think that's a key point to take in mind, because every day I have that conversation of, why am I going to get the flu vaccine when it's only 40% effective? Well, sure, it might only be 40% effective at preventing you from getting influenza, but it still is having effectiveness at decreasing your need for needing medical assistance. So from needing to have a clinic visit, from needing to be in the hospital. So, really talking about vaccination, not as primary prevention, but also prevention from complications. Don't ever underestimate the importance of hand hygiene. I do not get sick at work. I do not get sick from my patients. I do not get sick from the people that I work with. And I cannot help but believe that is because I am cleaning my hands 60 times a day. I get sick from my own family. I get sick from my kid being up in my grill. I get sick from kissing my husband. Those are the people that get me sick. It's not the people I come into contact every day at work. So think about hand hygiene and the measures that we take to help prevent that spread. Along with hand hygiene, think about where your droplets are going when you cough or when you sneeze. Try to aim them into your elbow or away from other people. Give them a surface to land on so that they're not suspended in the air. Wear a mask if that's something that you can do. Reducing your exposure. This is both when you're sick, but also during the peak of respiratory season. So stay home if you're sick. Those early days of your illness are when you're most contagious to others. So do the responsible thing and stay home, even if that means missing Christmas. I do not want to be responsible for giving my great grandma a cold or influenza, or for the new baby in our family to get RSV. I just don't want that on my shoulders. So I'm going to stay home if I'm sick. But I'm also going to try to avoid crowds as much as I can too. And that's hard to do because we have a lot of really fun gatherings in the winter. We can't always play outside when the weather is bad. So we're going to move our play inside. But just thinking about, when those illnesses are at their peak, maybe think about, especially if you're at particular risk for infectious illness, you might want to think twice about being in those situations. And then our environmental hygiene. This is important in our homes, in our clinic spaces, but also in our childcare and work settings, making sure our surfaces are clean. We're removing those infectious droplets from high touch surfaces. And then again, like I mentioned earlier, maybe there's a place for increasing humidity levels in our homes and in our classrooms. as a means of prevention. I think we're going to hear more of that in the coming years too, about those strategies. Vaccination is a key defense, and I don't need to tell this group the importance of vaccination any more than I already have. But just a couple key points. I've had a lot of questions about nirsevimab, which is the monoclonal antibody passive immunity immunization that we started last season for infants as RSV prophylaxis, and wondering about its effectiveness. In research, we saw with that probably a 70 to 80% decrease in the need for hospitalization for infants infected with RSV. In the real world, preliminarily, we're thinking those numbers are even higher. And it's tough to tell because we dealt with manufacturer shortage and difficulty with patients accessing that product during the season. Manufacturing has been ramped up. We've already started giving it in the clinic for this current season, and we're hopeful to see those numbers continue to escalate. And I find that many families are amenable to getting that immunization for their infants, especially when we start talking about RSV and the risk that's associated with it. A lot of people are on board. So I hope to see us being able to utilize that more as a strategy. The vaccine that's for elderly people and for pregnant women. So that's again using the strategy of passive immunity to protect baby. That is also very effective in preventing hospitalization, maybe not quite as high as nirsevimab, but still probably reaching that 75% rate of decreasing hospitalization. So we'll see more evidence come out as the season goes on and we learn more about those strategies, but that's really a game changer, I think, in the world of RSV. Addressing vaccine hesitancy. This is huge in our patients that we care for. And a lot of people are very on board with the recommended vaccines. So they're getting their regular infant vaccines, but they're more hesitant when it comes to these infectious respiratory illnesses. So we're talking flu vaccine and COVID vaccine in particular. As a refresher for everybody, both flu vaccine and COVID vaccine are recommended for all patients greater than 6 months of age. So that strategy has not changed. That is something that we as pediatricians still recommend. I think there was maybe a softening the last couple of seasons about recommending COVID vaccine, and there was some, kind of hand wringing or back and forth about it. But when you look at those numbers that I shared about hospitalization rates for COVID in kids and death rate for COVID in kids, and we see those numbers possibly approaching, what we would see in a mild to moderate influenza season, it makes sense to help be protective in that realm too. NDSU has the Center for Immunization Research and Education, known as CIRE, and they have a ton of material available for clinicians or community health providers, or even the lay public who are interested in addressing vaccine hesitancy among the people that they're around. And I think the highlights of this I kind of laid out here. And the big things make sense, right? When you're talking to someone about something they feel passionately about, you should approach them with an attempt to listen and empathize with their position, and approach with curiosity. Ask questions. Well, that's interesting. Why do you think that? Well, I haven't heard that before. I want to know more about your thought process with that. Ask with an open thought to understand where they're coming from, because then you may understand more about their motivations. Utilizing motivational interviewing skills. There is a video tutorial on the CIRE website about how to implement motivational interviewing. And it really, again, motivational interviewing looks at finding common ground with the person that you're working with and building from there. So finding what's the base thing that we agree on. Hey, we both want to protect your child from respiratory illness this winter. Everybody's going to get on board with that. Who is going to say no to that? And then you work your way up from there. Well, what are the strategies we can talk about? What are you willing to consider? And work your way through that. And then you'll ask their permission to share credible information sources, and by making a firm recommendation. Research shows us that when someone is vaccine hesitant, a recommendation from a trusted medical provider is the #1 thing that helps push them towards getting the vaccine for themselves or for their loved one. So I'll often say, I very strongly recommend that your 6-month-old get influenza vaccine this year. I chose it for my own family. I recommend it for my nieces and nephews. I think it's a good choice. I wouldn't recommend something for your child that I didn't think was safe or important. And really coming out and saying, this is what I think you should do. So those are just some strategies to share and things that I use in my own practice. But just for those of you that deal with those vaccine conversations, that's a way to approach it. I'm going to buzz through kind of these last few slides here just so we have a little bit of time for Q&A, but basic home care, again, majority of the time, these are illnesses that can be managed at home and do not require medical care. Stay home until you're fever-free for 24 hours and your symptoms are mild, absent, or at least improving to the point where you can function in your work or school setting. Make sure you're well hydrated, using pain medicines for discomfort. You can use steam or mist if it helps, and in cold areas particularly helpful. There really is not a big argument to use cough medicines or decongestants. A lot of that is placebo, and some of them may even be harmful for kids under the age of 6. So use with caution, talk to your medical provider if that's something you're considering. Time is the biggest healer of all, and allowing your body's immune system to fight off the virus and recover, and judicious use of antibiotics for the bacterial infections we discussed. You cannot tell if an infection is viral or bacterial based on the color of snot. That's a common misperception. This kid has clear snot. I don't know if this is viral, bacteria, allergies. Who knows? Something is going on with him for sure, though. When to come see me. So there are times where your kid might be a little bit sicker and you want to come see the pediatrician. So if you have symptoms in an infant less than 3 months of age, we typically want to see you in the office. If you've got a fever that's lasting longer than 3 days, any difficulty breathing, we should see you, especially with chest pain, decreased urine output. And then on the flip, if you've got symptoms that are outside of just sort of a typical cold, so you've got ear pain or you've got wicked sore throat, if your symptoms are lasting longer than 10 to 14 days, or if you have concerns for possible pertussis exposure, if you know you've been a close contact and you've had respiratory symptoms, that's a time you need to be seen and be tested. This is a little plug for antibiotic awareness. You will see that the most common respiratory infections, a vast majority of them, do not require antibiotics. Even the things that we still think about as bacterial. Some cases of bronchitis are bacterial. Ear infections are sometimes bacterial. Sinus infections are sometimes bacterial. Those are not a necessary automatic antibiotic prescription. And that's a conversation you should always have with the provider when your kid is being evaluated. And there are several factors that go into the decision to treat or not treat. But strep throat and whooping cough, yes, antibiotics for those. If you'd like more information, these are a few resources for you. I had mentioned in the vaccine hesitancy portion, asking permission to provide a trusted resource for vaccine information. I love the Children's Hospital of Philadelphia website. They have a vaccine education center that is marvelous, and it goes through every vaccine you can imagine, talks through the common concerns or even not common concerns that people have about vaccines, whether it's the too much too soon debate, whether it's concern about the preservative ingredients in the vaccine, whether it's use of fetal tissue or fetal cells in the manufacture of vaccines, you name it, any concern someone has had, it is addressed on that website in a very easy to read, approachable way. So that's what I got. I want to make sure I have a little bit of time for questions here too.
Wonderful. Thank you so much. I think I'll quick share my screen so I can get this information up for everyone. So before we move into questions, I just want to get the QR code to take the survey while we do move into those. And it looks like we have one in the chat, Dr. Hanson. And it's thoughts on Pedialyte versus Gatorade versus liquid IV or similar when not taking plain water well. That's a good question.
That is a great question, and one that I frequent quickly. We all know kids are fickle and they want what they want when they want it. And so if the kid is only, sort of mildly dehydrated and not a lot going on, I honestly don't care what they drink. You could pick any one of those things. The more important part is just getting some fluids and some form of, glucose into them. So whatever your kid is willing to take, go for it. I don't know if you've ever tasted unflavored Pedialyte. It's kind of disgusting. And I even think regular Pedialyte doesn't taste that good. So whatever you happen to have on hand. And if they want to drink apple juice, if they want to drink breast milk, you go for it.
Wonderful. Do you have any thoughts or recommendations on a thermometer? Like, because I know I personally have a few, and some of them give different reads. So I usually take it 3 times. Do you have any recommendations on the best one that you would recommend?
Well, I think the best one is the one you feel comfortable using. So,
Yeah.
a rectal thermometer is always going to give you the most accurate reading, but not everybody feels awesome about using that or feels comfortable using it. At my house, I use a temporal artery scanner, and I like that one. It's a contact thermometer, but you got to read the instructions. You got to be familiar with the drawbacks of them and understand when's the right time to measure the temperature. But I will just put in a plug here that realistically, the exact number of the fever or the height of the fever maybe isn't as important as people think that it is. Certainly in young infants, especially infants less than 3 months of age, yes, we want to know if they have a fever. We won't, because they are at higher risk for serious bacterial illness. But any parent or guardian can tell you, you can touch your kid's head and know if they have a fever or not. And they've actually studied it, and that mom's hands are quite effective at knowing if their kid is febrile or not. And I think it really depends a lot more on how the child looks otherwise. Are they having difficulty breathing? Are they taking in fluids? Are they playing and interacting with you? Are they just a slug? Have they felt that way for 5 days and they're not getting any better, or is it getting worse? I think those are the things that you want to be looking for rather than like what's the exact measurement from the thermometer. So even if your thermometer is a degree off, you're still going to know, is it a fever or not, realistically, and how long it's been lasting.
Wonderful. Thank you for that. I don't see any other questions that have come in. Any other last words?
People always ask me what's going around right now. And I think that the minute school started, we saw a big uptick in respiratory illness. So in our pediatric urgent care, we're seeing a lot of coughs and colds. But all of our urgent care providers have commented to me that they're seeing an uptick in pneumonias this fall. And I'm not really sure what the reason for that is. None of us do. But we're definitely seeing things skew a little bit heavier into both the mycoplasma and pneumococcal pneumonia. So that's just something noteworthy, and just seeing kids that have had maybe a little bit more significant cough or a little bit longer lasting.
Yeah, I have noticed a lot of coughing everywhere.
Yep.
Definitely. All right. Well, wonderful. Thank you so much, Dr. Hanson, for delivering such important education. I really enjoyed the humor mixed in with it, although it is a serious topic. That was always a nice touch, and your case study too. Thank you for presenting on that. And thank you to all the attendees who could make it today. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, Twitter, and Foundation for a Healthy North Dakota on LinkedIn. Also, to join the coalition, you can visit the link to stay aware of future webinars and updates on the foundation. And then there's another chance to scan the QR code if you're able to. And the survey will also be sent out with the recording. So I think that's it. So thank you again, and have a good rest of your day, everyone.